DA Ryan on the call, but thank you all so much for being here. We're so excited to have some really excellent guest presenters. So we want to go ahead and get started. And as we work behind the scenes to try and get District Attorney Ryan on, joining remotely. First up this morning, we are so grateful to have Dr. David Holdgrave here with us. Dr. Holdgrave currently serves as the Assistant Director for Translational Research in the White House Office of National Drug Control Policy. He's also appointed as the Adjunct Professor with the Department of Health, Behavioral and Society at Johns Hopkins Bloomberg School of Public Health, the department he chaired from 2005 to 2018 when employed full-time at Hopkins. From 2018 to 2022, Dr. Holdgrave was the Dean SUNY Distinguished Professor and SUNY Empire Innovation Professor at the School of Public Health at the University of Albany, where he is on leave from the faculty while performing federal service. Dr. Holdgrave's research has focused on the effectiveness and cost effectiveness of a variety of HIV prevention and care interventions, including the provision of housing as a structural HIV/AIDS intervention, and the relationship of the findings of these studies to HIV prevention policymaking. Dr. Holdgrave's scholarly works include over 325 professional publications. He previously served as the director of the Division of HIV/AIDS Prevention during President Barack Obama's administration. And most recently, Dr. Holdgrave has worked intensively on COVID-19 projects conducted in partnership with the New York State Department of Health. We have been very focused in this task force, and the DA has been focused about the rise of xylazine that we've seen here in Massachusetts and drug seizures and the data we have collected on overdoses. And we've held trainings. We had one yesterday with Dr. Jawa from the Graken Center. So we're really thrilled to have you here, Doctor, to speak about your efforts, and thank you so much. I'll turn it to you.
Great. Thank you so much, Madeline, for that very kind introduction. And it's great to be able to see everyone here. I actually did my postdoc years and years ago in Middlesex County. So it's nice to be able to participate in this opioid task force meeting that the district attorney has pulled together. So thank you very much. And if it's okay, I will try and share my screen here so that I can show a few slides. I think we can move more efficiently if we do that. Can everybody see my slides? Okay, you see the first one? Excellent, great. I'll dive in and just take a few minutes to run through a few slides, and then if there are comments, questions, suggestions, would love to be able to hear from you and also to stay in ongoing contact. Biden-Harris administration designated fentanyl combined with xylazine as an emerging threat to the U.S. in April of 2023, as I'm sure many or all know on this call. And when I talk about xylazine today, I'm usually talking about fentanyl combined with xylazine or adulterated with xylazine, but sometimes I'll just say xylazine for short, but generally mean it as an adulterant. When that designation was made, it received a fair amount of attention because it's such an important public health issue. I think xylazine has really had a tremendously negative effect on a number of people's lives, from overdoses to morbidity associated with really severe wounds. So there was a lot of attention focused on this. And it's the first time an administration has used this authority under the Support Act for the executive branch to declare something an emerging threat in the United States. Also, the history of xylazine goes back quite a few years. In 1962, it was developed as an antihypertensive for humans, but it was not approved as such. In 1972, though, the FDA approved it as an analgesic for use in veterinary medicine. And most recently, in the last 3 years or so, seen a lot of increase in its use and the impact of xylazine. Xylazine, of course, I think is many people have heard and sometimes known as tranq for short, as a name of a drug combination of fentanyl adulterated with xylazine. It can be ingested by injection, which seems to be the normal route of use. It could also be pill form and other forms as well. Comes in liquid form and powder form. When combined with fentanyl, may make the experience a little bit more like a heroin-like experience, a little bit longer lasting, a little bit more like heroin. In some markets, especially Philadelphia and others, xylazine is so cheap and so pervasive in the market, it's very hard to avoid it now. And maybe there's some diversion from veterinary medicine. There also seems to be concerns about online purchases, including from other countries, and even the adulteration may be taking place in other countries as well too. And I should say that while some people may seek out fentanyl adulterated with xylazine, in many cases it may be that people encounter it in the drug supply and then either seek it out after that for that experience, or may want to avoid it entirely without ever having used it, or after using it wish to avoid it. And so really a mix of reactions about whether or not people may seek it, or what their choice may be after experiencing the effects of xylazine. So just wanted to quickly note that. Also, we see a lot of expansion in the U.S. Of xylazine. This is from 2019 to 2021. You can see the growth in the maps of the number of states having xylazine-involved deaths. The DEA now says that they are encountering xylazine in 48 of the 50 states, so it continues to grow. And these are just some numbers from the October 22 DEA report that's online and publicly available of the 4 major census regions in the U.S. for the years 2020 and 2021, what the percent increase looked like in both drug seizures and in xylazine-positive overdose deaths by region. So you can see the large percentages of growth, not always the largest numbers depending on the region, but very large percentages of growth over time. And recently we had a paper in the New England Journal of Medicine, and I think the key takeaway is that xylazine really does seem to pose a threat to public health. And our goal for the designation of fentanyl adulterated with xylazine as an emerging threat, and the subsequent actions that I'll talk about in a little bit, is to begin to address this before it worsens and undermines efforts to reduce illicit fentanyl use in the U.S. So one thing with this using the emerging threats designation is it's really using the authority of the 2018 Support Act to try and get ahead of an emerging threat rather than waiting until something worsens and worsens, rather to try and identify it early and address it as early as possible. Of course, that means we don't necessarily have all the answers on all the things we would like to, but it means there's an earnest attempt to try and intervene as quickly as possible. From the same paper, this is just the number of xylazine-involved drug poisonings in the U.S. from 2018 through 21. Again, you see the growth here going up rapidly over time. And then going back to the issue of designation as an emerging threat, earlier this year, ONDCP published the emerging threats criteria after consulting the Emerging Threats Committee and others. And basically, these emerging threats criteria say that if a new novel drug, pattern of use, whatever, is being seen in 3 of the 4 major census regions of the U.S. and is increasing more than 15% year over year, that the director of ONDCP may consider at that point wanting to designate something to be an emerging threat. And I think clearly there's enough information about xylazine to declare fentanyl adulterated with xylazine an emerging threat. Of course, that doesn't mean we have all the data we would like, but rather that we have sufficient data to say that it meets these criteria for an emerging threat. On this slide, I just wanted to highlight the fact that xylazine sometimes is used alone, but very largely it's an issue of polysubstance use. And you can see it's when it's used in combination with other drugs, it's often in the presence of fentanyl, sometimes other drugs that are listed here as well. But the most common pairing with xylazine is fentanyl. And in some areas, fentanyl, now we're seeing larger and larger percentages of xylazine being present. The next couple of slides, I will just say in advance, I'm going to show a couple of the pictures of the wounds that are associated with xylazine. So I just wanted to give that graphic image warning before I move over to the next two slides. So this also is from the same New England Journal paper. This is a picture taken by Sarah at Savage Sisters in Philadelphia of some of the wounds. And I think many of you on this call have either seen these wounds or are caring for persons who are experiencing these wounds. They don't necessarily always appear at the point of injection. They may appear at on other parts of the body. And they can be very severe. They can go as deep as the tendon or the bone in some cases, and in some cases may require amputation as well. And here's the second slide with some of these pictures. More is trying to be learned rapidly about the causes of these wounds. It may be due to vasoconstriction and local tissue damage that's being examined. Also, given the profound analgesics effect of xylazine, it could be that if someone is in one position for a long time, some of these could be pressure sore-like, or maybe that's worsening the effects of these wounds due to other causes. So this is a topic of considerable investigation right now, as is approaches for wound care. That was the end of those two slides of the pictures. Also, just to say that yesterday, NIDA had an important meeting bringing together people who are providing clinical care around wound care, drug treatment, and testing, and trying to compare best practices for how to do that. And I think there's still a lot of questions, but a lot of sharing of information. So besides wound care, there's the issue of withdrawal treatment, and the experience of withdrawal from xylazine seems to be particularly acute. A lot of experiencing of anxiety that results from that, to the point that persons who might be in an emergency department or healthcare facility may leave against medical advice because of the experience of the withdrawal. And again, as I mentioned at the NIDA meeting yesterday, this was discussed of what clinical providers are using what strategies to try and provide drug treatment. And say if someone comes in with having ingested fentanyl adulterated with xylazine, one needs to treat the opioid withdrawal, but also try and treat the xylazine withdrawal as well, two separate processes. And different people are trying different things. Clonidine and so on are being used. And I think we're now in the phase where people are sharing a lot of that clinical information, but there's not just one best practice at the moment in the field. There's empiric treatment going on and people sharing that information. Also, just to say with regard to testing, of course, there's at least three different kinds of tests we could be talking about. One is kind of public health labs, toxicological testing. That's certainly possible and goes on in a number of areas, but not necessarily all areas of the U.S. in a uniform way right at the moment. Also, testing done this way might take a matter of days, perhaps, and might not be useful for a clinical diagnosis. So this testing is possible, but not yet, of course, uniform in its utilization. Secondly, one thing that needs to be further developed is a clinical point of care test. So if someone is providing clinical care in an emergency department or elsewhere and wants to confirm that xylazine may have been used, it would be great to have further development of a point of care test. A third kind of use, of course, is drug checking in the community. And now there are xylazine test strips, just as there are fentanyl test strips that are available that are now coming into the market. Some states are starting to make these available. And if one has grants from some federal agencies and talks to their project officer, they may be able to utilize some of those funds for purchasing xylazine test strips. Of course, if it's the issue of whether or not something is legal in your state or locality. But that's an important advance forward, because in some areas, like Philadelphia, this xylazine is so pervasive, you might assume that it's in the drug supply. In other areas of the country, it is increasing, and a xylazine test strip could be really informative if someone wants to know whether or not it's in their drug supply. Also, I think it's important just to say that even though xylazine is not going to be reversed by naloxone, of course, naloxone will address opioid drug poisonings. But we don't want to give up on using naloxone to address opioid poisonings. And I think that's just a really important message. You know, everybody on this call on the opioid task force knows this, of course, but just in public messaging, I think it's really important that we all let people know that just because xylazine is out there doesn't mean we should give up on naloxone in any way. And to use that to address the opioid poisoning, but it just means that revival may be more difficult. We may have to be focused even more on assisted breathing and so on if xylazine is also present. So I just wanted to make that point. And then last couple of slides to wrap up. There's been a number of federal and state actions. A number of states have now, about 5, I think it is, have scheduled xylazine as a controlled substance. It's not yet at the federal level. There are some bills in Congress that would schedule it, but those have not gone through yet. So at this moment, it's not scheduled in the federal level, but it is in some states. Also, a number of states are issuing local warnings, and I just happen to have the New York one here. There are others that are being put out. And then for federal actions, going back to October of 21, some actions from the DEA, FDA, ONDCP, SAMHSA, and others, either alerting people through their colleague letters, issuing alerts, or alternatively taking action, like where FDA wanted to start really carefully inspecting imported packages of xylazine to make sure they were going for illicit use in veterinary medicine and not illicit use otherwise. And as I already mentioned, there's a lot of interest in Congress around xylazine, and a number of bills have been introduced. And then just lastly to say about next steps, we've already covered the points in the left-hand part of this slide, but just to say, we're required at ONDCP to produce a national response plan within 90 days from that April 12th designation, so by July 11th. And now in clearance process is a national plan, so I can't go into all the details today, but it's fair to say that there'd be at least these 6 kind of pillars. One is trying to find ways to increase xylazine testing availability in all the ways I talked about before, getting even more comprehensive data, developing wound care and treatment regimens. Again, there's a lot of great work that's going on out there already, but refining that and being able to share that, addressing any questions about exactly where is the xylazine coming from, and addressing issues around illicit supply. Regulation, mainly meaning potential scheduling, and whether that would happen, if it does or doesn't, but whether that would happen through the FDA, DEA, or through Congress. And then also basic and applied research questions. And I just wanted to highlight that this week, NIDA came out with a notice of special interest of research availability funding around xylazine, which is really an important and broad announcement that they've just came out with. So I wanted to highlight that here. These are a few just links to some of the resources that I talked about before from different of the federal agencies, and just my contact information. And if you have thoughts, suggestions, questions, always invite the input and welcome it. Absolutely. So with that, let me stop sharing my screen. I'll turn it back to you. And if there's any quick comments, questions, or suggestions, would love to hear it. And also always love to learn more about what's going on in Middlesex County and any initiatives that you have underway there in this regard. So let me stop there.
Doctor, I'm Marian Ryan. I'm sorry not to have been untrapped in Zoom land to be able to greet you, but thank you. That was really an informative presentation, and we're happy to share with you some of the work of this very committed group. But if I can, before I open it up, I had a couple of questions. One is, I think you heard yesterday, we hosted a training about xylazine. And one of the things that we talked about, and similar to something you mentioned, was the reality of wound care and the challenges it presents, particularly for those who are unhoused. And I know you've spent an amazing career really doing extraordinary research and writing and thinking about this. And I wonder if you could tell us a little bit about what you think the role of housing plays in really having an effective intervention. And we have some folks on here who are in a position to affect those decisions in their communities. So I really want to explore that a little bit.
Oh, thank you very much. I really appreciate that. I agree with you. I think housing is really centrally important. I'll go back to my HIV work just for a minute, and we did a study where we could show actually that if persons were able to receive housing, stable housing, that actually you could show an increase in viral suppression over time. So actually a biological improvement in viral suppression as a function of housing. And I think that literature on the importance of providing stable housing as a kind of structural intervention, whether it's addressing substance use issues, addressing infectious diseases like HIV, is really central. In fact, it could be thought of as a kind of medical intervention, I think, in a way. And when I was in Albany, one of the healthcare providers there had come to the place where they were sort of prescribing, if you will, housing as a way to provide healthcare, that for some clients, you really needed to make sure that you were providing stability in housing. So I think that's incredibly important. And I agree with the point that when we think about housing and xylazine, the wound care can take place over a fairly long period of time, and if that's the case, being able to have a stable place, you start with water and soap to provide to be able to clean wounds, clean bandages, and so on. And while one can do that, perhaps to some degree, if you're not stably housed, it's so much better if you are stably housed and are able to do some of the wound care will happen as a function of harm reduction professionals, other healthcare providers. But self-care for some of the wounds is incredibly important because it can take place over a long period of time. So I just want to say, I do think stable housing is an incredibly important social determinant to address here. Absolutely.
And just another question, Doctor, from your work in this area, could you give us some recommendations? This very diverse group that includes those in public health, recovery coaches, law enforcement, ADA, district attorneys. What do you think is the most effective way to address this crisis using an equity lens? What has the most impact?
Thank you. I think one thing that we need to do is to be getting even better data as we go forward. As I mentioned before, we've got a sense from the early data that, yes, this is an emerging threat. This is really something that's a crisis that we need to address. I think as we get even more comprehensive data, we need to constantly be looking at what are we learning about disparities by different communities, and making sure that we're providing services in those communities in proportion to the burden that's being experienced. So I think that's incredibly important. Also, I think as one considers the response here, we can look at some of the social determinants that have already been in the literature associated with health disparities. And I think your question earlier, District Attorney Ryan, about housing is such a good example. If we know that some of these social determinants like income inequality, housing, stigma, discrimination, and so on, are affiliated with disparities, we need to be robust in including those as part of our response as well, too. So I appreciate you raising this. And I think the other thing I just want to say quickly, too, is I think we need quickly to get best practices out in terms of wound care, drug treatment, and testing. And as that rolls out, we need to be mindful of who's getting access to those services as well, and making sure that there's equitable access to those services and equitable outcomes from those services as well. So those are just a couple of thoughts.
Doctor, you've been incredibly generous with your time and experience. I'll just open it up briefly. Anybody else have any questions, comments? The doctor? Just unmute yourself.
I have a quick question. Relevant to housing, because of the stigma with transitional housing, some obviously hide this because they don't want the stigma of, oh my goodness, I'm using and I'm going to be terminated from housing and what have you. With those of us that they may trust, they may show it to us. I don't know of anything over the counter that I can recommend to them other than I will take you to the hospital or whatever, other than cleaning and what, but some are very covert about it until it gets to a point where there's so much damage that you fear for their life, you fear for amputation. So.
No, I think you raise a really important question, and to whatever degree it's possible at all, and I'm just commiserating, not adding to, I'm sure, what you just said, but is I think trying to make sure that people feel comfortable in coming forward and addressing wound care in particular is really critical, because I do think one of the things we're starting to see is that if you can address the wounds earlier rather than later, the recovery process can be a lot shorter. They can be addressed in different ways. And if the wound is more superficial before it gets to tendon, before it sadly gets all the way to bone, there's more that can be done. Also, the wounds aren't just automatically infected, if you will, at the front end, but could become that way if, say, for instance, someone doesn't have access to soap and water, is unstably housed. So early detection, I think, is really an emerging issue that's really important. If someone sees the beginning of a wound, they have a concern, the more they have somebody that they can talk to, either through the housing provider, through a harm reduction professional, through someone in healthcare, or a peer in the community, to be able to talk through how can I get access to wound care as early as possible. That only increases the possibility of as good an outcome as quickly as possible. So I really appreciate you raising that point.
Thank you, Doctor. Thank you so much for being with us. And we're happy to send you some information about what we've been doing here as well.
I really appreciate that. Thank you very much. Take care, everyone.
Thank you. All right. Before we go on, and I apologize for my being in internet land and not being here at the beginning. But I want to do what we normally do in the beginning, which is go back and talk a little bit about our numbers. I also want to thank everybody who was able to join us yesterday for the xylazine training, and we can make that available for people who are not here. You'll remember that we last met as a group on May the 18th, and we talked about information at that meeting through May 12th. So from May 12th and through June 9th, we have tragically experienced an additional 12 overdose deaths. They are, as we continue to expect, and you'll see in a second in the map, scattered across the county, with a continually large number in the eastern part of our county. And of the reports that we already have back, we see fentanyl in almost every one of those, whether the vehicle was cocaine or heroin. So that just reminds us that as much as we're talking about xylazine, fentanyl continues to be a concern. And also in doing what we always try to do in looking at the human piece, among those 12, they included these 4, which I think speak to some of the issues we've talked about. One was a woman in her 60s, a long history. She was using crack cocaine with a friend. The friend had a neighbor call 911 when she began to overdose, but much too late when they arrived on the scene. Another was a young boy, not quite 18, had returned literally the day before from a rehab facility and was found by his dad. A man in his 50s with a long history and found by his son. A man in his 20s found by his mother. She also found his girlfriend who was overdosing as well. She survived that. And I think it just reminds us of that human connection. You know, every death is tragic, but the circle of people impacted by that is really concerning. And when we look at the numbers, as difficult as those 12 are, we do see, and it is all because really of the work of the people on this call. We fortunately are still in a position where our numbers are back in decline. For this period last year, from January 1st through June 9th, we had 106 non-suicide overdose deaths. And this year we are at 89. So we've had a reduction of 17. And again, when I talk about that circle, it's 17 plus the people who've been impacted by that. We have continued to see an increase in the number of suicide using substances, especially pills. And that is very concerning. Especially, remember, I always say we only will call something a death by suicide when it is unassailable, when there's a note, there's something very clear. There are many others that we might have a question about, but we don't determine that to be a suicide. I also want to make sure that folks are aware of some of the things we talked about at our last meeting, the new resources that we heard about, the state's new community behavioral health centers. These centers are really one-stop shopping for lots of mental health and substance treatments programs. There are 25 of them. They offer immediate care for mental health crises and substance use. And they're open, they are available 24/7. So they are insurance blind. The stabilization and outpatient services are available to all Mass Health members and may also be covered by commercial insurers. So we'll put information in the chat about that. Since our last task force, I had the opportunity to talk at Waltham High School, joined by a parent from California. Laura Didier lost her 17-year-old son, Zach, the day after Christmas, to a pill that he had purchased on Snapchat, documented as being only the second time he had ever used pills or other substances. He and a friend had bought pills that were Percocet. They used them once. He decided to buy another pill. He received a pill marked as Percocet, but it contained a deadly amount of fentanyl. And we talked to parents about the drug supply, the fentanyl that we are seeing, reminding them of the 15,000 pressed pills that we seized just in April that contained both fentanyl and xylazine. The young man that I talked about just a few minutes ago, the young man in his 20s where his girlfriend overdosed and she survived, really speaks to what is the most dangerous property. And I know many of you know this of fentanyl, that it often clumps in a substance. So you can have a batch or you can have pills and you don't happen to get the incredibly powerful clump and you survive and someone else does not. It was really a very moving experience to hear from Laura. She's really dedicated her life now to spreading that word about the risks that kids may not be appreciating. So I also want to give a special shout out to Patty McCaffrey, the Director of Health Services for Waltham Public Schools. She hosted that event. I also sadly want to give her a shout out for the service she's given to the schools, congratulate her on her retirement. I would be much sadder about that if it were not for the fact that Patty is going to stay involved with the task force. So I'm very, very grateful for that, because that makes her presence has made a huge difference. She's been one of our staunchest members from its very beginning. The other piece that I want to mention, because you'll be seeing them soon, is, the Surgeon General in his most recent report talked about the fact that of all the things we can be doing to address these issues, an important piece is encouraging social connections. And that so many people, especially young people, lack that ability now to form a real social connection. Their life exists on their devices. So one of the ways that we are going to be looking for that, a new initiative, is called our Let's Connect benches. We researched this idea and found that Manchester, England had really developed this. They had sponsored and put benches in very public places, encouraging people to sit down and chat with people, particularly people across generations. So we have purchased a lot of those benches. We're going to be putting them out in communities. We are especially looking for communities where we can put the bench in a place where it would be accessed by all age spectrums. So if you have a place in your community that you think would be great for that, reach out to us. We'll be happy to put that out there and give people an opportunity to use those. All right, next up, we are really pleased to have one of our own members of the task force with us. Lauren Lele is here with us. Lauren serves as the Senior Director of Community Benefits and Volunteer Services at Newton Wellesley. Newton Wellesley has been a host to this task force for a number of years, and Lauren has really been a mainstay. She's responsible for strategically leading the 8 councils within the Newton Wellesley Community Collaborative. And she's been in the field of hospital management for over 25 years. She, in addition to her work at the hospital, holds leadership positions on multiple community, civic, and business boards, including the Waltham Chamber of Commerce, the Newton Food Pantry Advisory Board, and she's also a member of the American Hospital Association for Community Health Improvement. I was grateful this year at Lauren's invitation to speak at the Community Collaborative's annual summit, and really to hear about those amazing councils, the variety of people they have engaged in this work, and all that they are doing to really assess what the needs of their communities are, and then put together groups of folks to address that. So I'm going to turn it over to Lauren at this point to tell us a little bit about that work. Thanks, Lauren.
Thank you, DA Ryan. Thank you so much for having me. I am going to share my screen. It's a pleasure to be with everyone this morning. I'm hoping everyone can see that. Is that okay? Mm-hmm. All right, great. So as the DA said, we have the opportunity this morning to give you an overview of the Newton Wellesley Hospital Community Collaborative. And so what I would like to share is just a few slides about the hospital itself, give you the background of the collaborative and how it really came to be, as well as the current state and what we're working on and kind of the why behind that. And then also, as we look forward, the impact that we hope the collaborative will make in the future. And so here are just some numbers for Newton Wellesley. I know many of you are familiar with the hospital. It's an acute care hospital. We have over 3,700 employees and all inpatient and outpatient services to include emergency medicine as well as surgical services and several off-site locations for some of those services that we do provide. Newton Wellesley Hospital is a member of the Mass General Brigham system, and you can see all the facilities that are included in Mass General on this slide. We sit in the community division for Mass General Brigham, which are the 6 hospitals you see at the bottom of that slide, and also to include the island hospitals. And so obviously the geography for communities that come to Newton Wellesley for care is quite vast. But in terms of when we think about our community outreach work and what we do in the community itself, we focus on six specific areas, and it's quite easy to remember because we call it the 3 N's and the 3 W's, and you can see those listed there for where we really dedicate our efforts. So as a hospital, not surprisingly, we have kind of really 3 very high-level overarching strategic areas of focus. The first, of course, is to provide exceptional clinical care in everything that we do. The second, which is embedded into that, is to provide an excellent patient and employee experience to really enhance the care we provide. And then third is really those community relationships that really impact all that we do and allow us to address what we see and what we hear and how we integrate into our community itself.
Oh, Lauren, sorry to interrupt you. I wonder if you click slideshow.
Yeah, sure.
Top and do presenter view.
Oh, yeah, sure. Sorry about that.
No worries.
That would be much better, I'm sure. Let's see here. I want to do it at the bottom to tell you the truth, but
from current slide, yeah.
Yep. Is that better? And then I think I have to, are you seeing the whole thing now? Or do you see the notes?
We do see the notes.
Okay, hold on one second. I just have to switch it for I have 2 screens going, so. How's that?
Oh, perfect. Yep.
Okay, great. Thanks for saying that. And so in terms of the organizational plan, community is embedded even more so in terms of how we go about our work. And you can see the 5 areas that we include in that. And then community is one of those to improve the health and well-being of the communities we serve. So the Community Collaborative was started as with a group of leaders with a vision to think about how we might create a model that was a unique way to respond to community need, as well as to resource that with community engagement. And so those leaders came together to think about this back in 2017. And I'm happy to say that many of those leaders are still engaged in terms of oversight and guidance for the collaborative, which is amazing. And the result has been, as the DA mentioned, the creation of 8 collaborative councils that address high need. And I'm going to put them up, but you could probably name them before I even put up the slide. But they also link to what we find in our community health needs assessment, which is conducted every 3 years at the hospital. And so these are the 8 councils. And as I said, not surprising in terms of what's on that list for areas that are of impact in our communities. And I think of note is that to say that these areas really cover wide ranges for ages, and they touch people at different points in time of their lives, as well as touch individuals, touch their families, touch their friends, touch their neighbors. And so really it's someone would be hard pressed not to have some connection to one of these councils in some way. So each of the councils has 4 objectives, and you can see those listed here. And I just wanted to touch on each of those in terms of how they are played out for each council, with stronger emphasis on the programmatic impact. So the council membership is actually almost 200 individuals, and that is comprised of Newton-Wellesley Hospital employees who work specifically or are connected to the space within the council. It is also organization and community leaders who are involved in these areas. And then thirdly, which is very important, are individuals in our community that have a passion, that have an experience, that have a connection or a desire to connect to Newton-Wellesley to help us further the work in these particular areas. The leadership model for the councils is a dual role. We have community council chairs and co-chairs, and then also a hospital champion. And this is an important piece because it allows the councils to have a connection a direct connection to the hospital leaders and strategically what is going on with the hospital. We are proud that also our board of trustees at the highest level, our board chair is actually a member of one of the councils, the Domestic and Sexual Abuse Council. And she has really promoted and continues to promote our board of trustee members to be parts of councils. And then we also have our board of advisors, which is another leadership group who are community members who are engaged on the councils as well. And I put this up here, I didn't put the names, but just to give you a sense for our hospital champions, the types of roles that are included as leaders for the collaborative at the hospital. And you can see that many of them are chiefs and chairs of our services, which I think is really telling in the sense of their support for integrating community health and community efforts into what they do in terms of their clinical care. So really who we are and what is our purpose? Obviously, we are looking to address unmet community needs. Many of these services are under reimbursed or actually not reimbursed at all. So that's an important way that we support what goes on in these spaces. As I mentioned, the integrated leadership, community member engagement, also education program and awareness, and then also not just coming up with ideas, but actually executing on those. And then the philanthropic piece, which I'll touch on at the end. And so the collaborative as a structure is really the why. And then the council is how we do that work and what we do in that space. So again, success factors, I think I've mentioned in terms of the critical piece of leadership from the hospital, being innovative, and also really linking this to community need. So I want to give you a couple of almost very brief case studies. So we first look at kind of what is happening in our communities. And I think this is definitely top of mind for our communities over the past year and really more recently in terms of postpartum depression. And so many of you know that 1 out of 7 women experience depression during pregnancy or postpartum, and that 30% overall are susceptible. And so we looked at this, knew it was an issue in our community. We have a strong linkage to the clinical service, which is an important component. And what happened back in 2019 was the launching of the Perinatal Mood and Anxiety Disorder Initiative. And so I think what's important here is obviously those numbers that have increased drastically over time. And the fact that we have a social worker who's now available for referrals both for during pregnancy, and you can see 42% of these referrals happen during pregnancy, but 53% have to happen postpartum. And what we incorporated is through the screening tool in that most women are screened at 24 weeks and then 6 weeks postpartum. We now screen them 6 months postpartum, which is considered the 4th trimester, which is a huge number of percentage-wise where we see the incidence of postpartum depression. And so now this is being researched at Mass General Brigham and is actually a program that's currently being rolled out throughout the system. So the impact on the numbers in terms of all those birth rates throughout our system is enormous. It's over 500 people here at Newton Wellesley, and so you can extrapolate that through all the hospitals. So that has really been a great outcome and continues, very unfortunately, to be something that needs to be addressed at this moment in time. We understand that support services are so important for this area as well. And so we have drop-in groups that are held twice weekly by our nurse midwife to really offer information and support to new mothers and offer that connection and engagement that is so important as people are learning to navigate and to struggle with all the things that come along in the birth of a new child. And then another case example, obviously important for this group here, is for our substance use. And as we can see, substance use disorder impacts 5 to 10% of the population. There is significant stigma and lack of education that really means that treatment is challenging to find, to access, and to take part in. And so also we have seen a shift to population health. And what that means is the interconnection of a substance use service with primary care, which is critical, as well as with community partnership. And again, linking it to what we hear in the community. And so what has resulted from that is that through our Substance Use Council, there has been extensive connection with our substance use service, which includes a physician, a social worker, a recovery coach, and a medical assistant with our primary care practices to help them to understand, to recognize, and honestly to know how to proceed in terms of a care when a patient presents to them with a substance use disorder. And so there's a number of different education platforms that happen, raising awareness around stigma and addiction. And partnerships are critical in all the work that we are doing with the collaborative. And so every year for the past many years, we have hosted the Purple Flag Project in collaboration with SOAR Natick. And you can see the picture there. It's placed on the front lawn of the hospital, which is obviously front and center on Route 16. And it's on display for over a month. And the DA, fortunately, has joined us in recognizing that project. And we have a program every year where we bring family members together and allow us to talk about addiction and stigma specifically. And then just to go through quickly the other councils, just to cite kind of where we make the connection. So Heart Health, we started an initiative where it's we've kind of turned it around where we want to take care of those who are taking care of us. And so firefighters are at significant risk for cardiovascular disease. And so we have created the Heart Health Initiative in most of the fire departments around us, and we continue to expand that for a 3-part series looking at and understanding their health specifically around cardiovascular disease. And then also expanding this to other populations that are at risk, specifically seniors, by holding the Walk and Talk Health program, the Small Steps to Better Health program with our senior centers. And then we're also piloting a program this fall for teachers, as we know the stress and level of what they are having to deal with in terms of student mental health, their own mental health. That risk is increasing for teachers. And so we're going to expand the program to that specific population. The Domestic and Sexual Abuse Council is focused on community resources and partnerships, and specifically looking at diverse populations and how they can access services and receive bilingual and ethnically appropriate services as victims of domestic and sexual abuse. The Elder Care Council, as DA mentioned, so important for connection in that we are focused on social isolation and have had extensive programming to engage seniors both through educational platforms related to health, but also specifically focused on fall prevention. We host the Matter of Balance program in collaboration with all our senior centers because we know the effects of being at risk for falls is enormous in terms of how that can impact someone's well-being, perhaps staying in their own home, receiving care, et cetera. And then the Palliative Care Council is focused on serious illness conversations and really looking at the end of life. And as we know, the experience for patients, families, and providers are really impacted by those last few months. And also there's a financial responsibility there in terms of the extraordinary care that's required during that time is really impacted financially across the spectrum as well. And then the last one here is resilience, or second to last, resilience for youth mental health, where we have a team who are in consultation with all of our 18 high school and middle schools. This is a team from our child and adolescent psychiatry division, which includes a psychiatrist, a psychologist, a social worker, and a school liaison clinician. And they do consultation in all the schools to fill gaps in terms of what they are seeing and what their needs are. They also provide education and professional development through our summit that we hold annually, bringing in national speakers and bringing together through discussion and breakout sessions, challenges and opportunities and trends around youth mental health in the schools, and then also parent workshops. And then the last one is our Workforce Development Council. And this is really to provide opportunities for economic stability for particularly youth, because we know that they are impacted in terms of graduation rates, socialization, obligations at home in terms of providing contributions economically. And so just to give you one example, for the past 6 years, we've partnered with Waltham Partnership for Youth and have hired 96 of their students into intern placements through the summers in both clinical and non-clinical assignments. And it's an opportunity for students not only to get paid employment over a full work week, over 6 weeks, but also to be exposed to healthcare and opportunities that they might not have been exposed to previously due to work demands. And then, as I mentioned, community outreach is an important objective for each of the councils. So we host a number of different platforms through virtual mostly, but we also have the opportunity to, now that we're in person, go out into the community at different events and highlight ways that we can support in each of these 8 areas. And then a lot of the council work also is being done across councils. And so that we see some exchange of topic areas such as planning for caregiving with the Elder Care Council and the Palliative Care Council. And then also, as we've talked about, the Resilience Council and the Substance Use Council have increasingly partnered, just because those 2 areas that they are focused on have such overlap. And it's really honestly hard to not include one without the other. So we're doing that on an increasing basis. All of the programs are placed on our YouTube channel so that they are accessible after the program and allowed for people to view as well as to pass along to others. And then I just want to highlight too, as the last objective in terms of philanthropy. And so we have had the good fortune of the past 2 years. The Community Collaborative has been the beneficiary of the Newton Wellesley Hospital Gala. And I highlight this because this year was enormously successful in raising $1 million. And the reason I say that is because there was such enthusiasm and commitment and desire from everyone in the room and beyond who really want to make an impact in all of these areas and really feel that both as a hospital, but as a community coming together in collaboration and partnership, that it is so important to address what is being seen in the community. So we were thrilled with that dedication that was expressed. And as the DA mentioned, we do have an annual collaborative summit every year, which brings all of our council members together and others together to celebrate, to highlight, to thank individuals who are engaged in this work and doing hard work and impactful work. And the DA was our keynote speaker this year. And what kind of prompted me coming today is really just there was so much intersection among the councils in terms of what she and her team see and what they are dedicated to across the state. And so we just were thrilled that she was able to be there with us. And it was wonderful to have her be able to speak on all of these topic areas. And so lastly, in terms of next steps, we hope to continue with alignment with our hospital board and truly integrate our leadership and the hospital priorities in everything that happens for the community collaborative and community health for the hospital. We're looking at how we use the funds that we have in terms of thoughtful and impactful ways, and really execute on the ideas that are brought forward. And then ongoing to review the impact and certainly attribute metrics to all of this work. And so I just put this slide up. I was having an email exchange with Ellen Maloney, our president of the hospital recently, and she ended her email with this quote, and I couldn't not include it here because I just think it speaks volumes to not only what we want to focus on, but really from a leadership perspective, where they are at in terms of the responsibility and the desire for the hospital to do this work in partnership for all that are around us. So our work to support our communities is at the heart of our mission. So I am happy to answer any questions if we have time, or certainly here's my contact information if going forward anyone has anything that they would like to share. So thank you.
Lauren, if you wouldn't mind, we'd just ask you if you mind sharing questions at the end so
Absolutely.
we can move
Yep.
to the next presentation.
Yeah.
All right, great. Thank you.
Yeah.
Thank you. I'm really delighted to have with us for our last presentation, Dr. Shakir Shrahu is an assistant professor at Tufts University School of Medicine and Public Health and Community Medicine. And his research has focused on the study of the opioid crisis with an emphasis on prenatal opioid exposure and associated health outcomes, opioid overdose events, and harm reduction. He received his PhD from the University of New Mexico in 2019, with his dissertation focusing on post-discharge healthcare utilization in infants who were experiencing neonatal opioid withdrawal. His current research primarily focuses on accessibility and acceptability of substance use treatment using geographic information systems. So welcome, Doctor, and I'm really grateful to have you here. And joining as well in our audience, also from Tufts, is Dr. Jennifer Putz, who serves as the Assistant Director of the Office of Student Wellness at Tufts. So thank you for being here.
Thank you, dear Ryan, for the invitation to present today. Let me share my screen so that we can begin. Okay, let's see. Does the slides look okay?
Yes, looks good.
Thank you so much. Thank you everyone for being here. And it's been great to hear the presentation before from Dr. Holgrave and Dr. Lele on all the work that they've been doing. I'd like to thank dear Maren Ryan and Madeline again for inviting us to present today. So today I will talk about one of the studies that we've been doing at Tufts, which is titled Syndromic Surveillance to Prevent Overdose in Lowell, Massachusetts, Data to Action and Evaluation. And before we begin, I'd like to thank the team members of our study group. So me, along with Dr. Jen Putz and Dr. Tom Stopka, are the MPIs of the study. And we also have program coordinators Kevin Sear, postdoctoral fellow Jack Cordes, and research assistant Olivia, Takyung, and Grace, without whom the work that we have been doing over the course of past year and a half would not have been possible. I would like to thank our collaborators, Jamie Dillon from Life Connection Center, Dr. Wilson Palacios from UMass Lowell, and John Kelly from Trinity EMS, as well as our sub-award grantees, Dr. Cece Bao from the University of Texas Health Sciences Center, who have been very vital in helping us do all of the work that goes along with the Stop OD Lowell study. Before I talk about the Stop OD Lowell study itself, I want to highlight some of the history of collaborative research in Lowell. We first started with Lowell Peer Education and Risk Reduction Study, the Lowell Peers Project. Dr. Tom Stopka take a big role in initiating this project, which initiated the first brick and mortar SSP in Lowell and piloted peer-educated models to reduce injection-mediated risk. And it also included GIS maps and spatial analysis to assess risks for opioid overdose. And along with that, there has been additional collaborative work going on in Lowell, which builds on the intersection of GIS, the Geographic Information Systems, and opioid overdose, examining the spatial risk tied to the opioid crisis and looking at a collaboration between public health, EMS, and academics so that we could understand where opioid-related overdose events are happening so that we could predict where the future things could be, so that it would help us plan on intervention that are aimed towards reducing the impact of the crisis. And again, the collaborators include Jamie from Life Connection Center, John from Trinity EMS, and we had worked closely with Lainey from the Lowell Public Health Department and Dr. Wilson Palacios. In addition, we had a broad collaboration with other stakeholders during the HIV outbreak among people who inject drugs, and the Lowell's Peers Community Advisory Board, the Lowell Mayor's Office of Opioid Commission, and the Opioid Overdose Data Subcommittee work closely together to understand what is going on and how we can come up with different intervention to prevent or reduce opioid overdose and prevent the transmission of infectious diseases such as HIV and HCV in people who inject drugs. And in more recent years, this is where we come to the Stop OD Lowell study, we had been working with opioid overdose data from the Registry of Vital Statistics and looking at that data and examining where people were having overdoses and what was involved in the overdose. We thought, if we want to take actionable interventions, we need to have more rapidly flowing data without the lag that we have basically took about 6 to 8 months for us to get the vital statistics data on mortality. So to reduce opioid-related incidents, we have to rely on 2 main steps. That is to rapidly detect clustered exposures and opioid-related incidents tied to fentanyl and other drug adulterants, and to efficiently facilitate communication between public health officials, safety officials, and vulnerable community members. However, we saw that there was limitations to the current system. A lot of the research that we were doing involved data that had a lot of lags, and there was a lack of a systematic information dissemination strategy for ORI alert. And I have shown on the graphic an example of one of the public safety alert that is regularly put out when a community experiences a number of opioid-related events. Basically, the LPD puts out kind of an alert saying there has been an increase in suspected opioid-related events. Please be careful. And these alerts serve as kind of a vital point in warning community members of increased risk. But even during evaluation of these alerts, we saw that there is a lot of room for improvement, and we could possibly, get or detect these increases in opioid-related spikes a bit earlier in time, and also effectively communicate the messages to the most vulnerable population. So the overall objective of this study was to improve the syndromic surveillance in Lowell by reducing the response time to opioid-related spike detection by 50%, to facilitate rapid dissemination of information. And in addition, we wanted to evaluate the communication channels through which these alerts are transmitted. That is, understand how the stakeholders, the vulnerable population, maybe their family members or other people in the community, were looking at these alerts and how they were reacting to it. And we hope that these findings will inform our work with stakeholders and optimize communication channels and streamline the flow of information so that these alerts are generated faster and communicated faster so that people can be careful or check up on their loved ones or be aware of what's happening in the community. So in this slide, I show kind of a graphic of what our information flow looks like. On the left panel, we have data and algorithms. So basically our study involves examining the EMS data, which collects incidents related to opioid-related events and feed that into data and prediction model that basically, which is akin to kind of examining meteorological data and pointing out where we might have a hurricane or a tornado before it actually makes a touchdown so that people can, take some precautions. And then on the right-hand side of the panel, we have people, that is stakeholders, alert recipients, and in the center we have the messaging, and this includes a dashboard, the messaging mechanism, and how it is transmitted. So all of these come together in the study that we are currently conducting in Lowell. In the next image, we have some pictures that we took during our study visit in Lowell. We do primarily a lot of recruitment at the Life Connection Center. This is the image of the RV that they have over there, and our study team during our early meeting in Lowell. We have Tom, John, Jen, and me over there just getting lunch and talking about the study. So for the first part, the first research objective of our study was to develop an ORI spike detection model. And we used trained EMS data and examine the priority codes, complaint codes, all of the information collected during an ED event, and EMS data captured during a patient event, and identify location of where the event is happening, and use all of that to create a model that predicts how many cases we have observed in the past 36 hours, 48 hours, and 78 hours, and develop a model that can predict what is going to happen in the near future so that we can understand the increased risk if there's any. This graph shows the trend line of the increase in opioid-related events in Lowell and kind of a slight plateau or decrease in the year 2021 and 2022. But again, in the more recent data, we've seen slight uptick. And the change in the wave pattern just show some of the seasonality associated with the opioid-related incidents. We usually try to observe some spikes during summer months. This graph shows some of the variation in opioid-related incidents by the time of the day and the day of the week. So the colors determine which day of the week it is, and the numbers at the bottom of the x-axis shows the time of day when the events are happening. And we see a lot of the events happening primarily during the latter half of the day, starting at around noon or 1 p.m. and peaking at around 5, 6, 7 p.m. So primarily most of the incidents happen at that time. So we use all of these information to identify, what time and what day of the week we are at highest risk of observing these opioid-related incidents. So going back to the analogy of the weather and meteorology, what we have been doing is observing cases of opioid-related incidents from the Trinity EMS data, and then looking at how closely these events were happening in time and in space, and looking at historical data to create a risk model to identify, where or if we may see increased risk of opioid-related incidents. And our hypothesis is that events that are closer in time and space are more likely to be related to each other. Therefore, these opioid-related incidents that cluster together are predictive of an ORI spike. So we don't have to wait for a higher number of cases, which is at this point is about 18 to 22 cases in a period of 72 hours. We could possibly take some measures to alert people by observing fewer number of cases, let's say less than 10, in maybe a period of 36 hours, thereby reducing the time to act to maybe an increased risk. So based on our models, what we saw that if we clearly identify the ORI cases using different text indicators in the patient care reports and use a prediction model, we could make early decision to generate an alert and highlight the amount of risk. We also saw a lot of seasonal and time-related variation in opioid-related incidents. And our models had a really good balance accuracy of about 82%, which is pretty decent when it comes to identifying alerts. And we also observed that if we identify the ORI cases much more clearly using the PCR reports, we don't really need to examine many cases. And about 10 to 12 cases observed in a period of 36 hours could be used to help generate alerts. And in our next step, we are doing some additional model tuning and automation so that all of this analysis feeds into a dashboard that might be available to the stakeholders who can easily access those information. And then the next part of the study, what we've been doing is evaluating the communication channels for these alerts. It is not just important to understand where these alerts are happening, but also important to understand what people do with it, what the stakeholders do with it, and what the actual drug using community do with the information. So what we did was we conducted qualitative interviews with opioid stakeholders and people who use drugs, and completed about 100 baseline surveys in the past 2 months and examined what people do with the information. So in the first part, we observed amongst some of the stakeholders that there was some lack of information of a formal opioid-related spike detection system. And there was also some concern about hidden population, that is people living in residential areas or individuals living alone were not getting some of these alerts, so that we identified possible channels where more communication is needed. In addition, when talking about different communication methods, a lot of stress was put out on, there was no wrong way to spread message. Any way the alert could be spread out to people that would be efficient as long as it gets to the relevant population. And there was also an emphasis on importance of word of mouth, that is communication, informal communication among people to spread the information. When we examined the qualitative interviews among people who use drugs, there was some conflicting information there. Some people responded that there was some increase in drug-seeking behavior based upon information about drug alerts, but there was also some information on people being careful and not, not seeking those specific batches, and being very careful about the community where they're using drugs. One important fact that came out was people claim that individuals with clean time were at very high risk of opioid overdose when there's an increase in opioid overdose going on in the community. And in addition, we saw that police and other social organizations, local agencies were trusted source of information when it came to increase in opioid overdose risks. And again, as we did with the stakeholders, we saw that there was no wrong way to spread the message out regarding increase in opioid-related incidents in a community. Word of mouth, flyers, text, emails, or Facebook messages, any and all information, formal and informal ways of communication were used to communicate these risks. We also completed about 100 interviews on our first wave of survey. This is kind of our pre-implementation baseline survey examining demographic information, substance use history, xylazine use and experience, nutrition, quality of life, social support, recovery, harm reduction, and knowledge on opioid-related incidents and how they communicate this. And in the interest of time, I'll just focus on the communication regarding opioid-related incidents. And we noted that about 40% of the people who we surveyed had received or heard of an official alert, but for the most part, they had not received the official alert themselves, but somebody else had told them about it. A majority of the people found it somewhat useful or very useful, about 50%. But many people noted that they did not receive the alert on time. About 40% said that maybe it would have been better if the alert were put out earlier, because through informal channels, they were very much aware of what is happening in the community. And they told that, yes, it would be helpful to receive the alert earlier, particularly in those among those people who may not be in the channel where the information is being shared. And again, best way to receive these alerts were news radio, social media, or direct text messages. So what have we learned in the first year and a half, and what are the opportunities? There were some barriers when we got started, in getting support from some organization. And again, there's additional inherent challenges working with EMS data and recruitment of study participants, but also they have wonderful opportunities. There are opportunities to integrate drug testing, which we do not have currently involved in the study, and the study of non-opioid users or recreational users of other drugs who may be at higher risk when there is a bad batch or contaminated batch going around. And also, there's ample opportunity to develop methods to identify ORI cases using automated system with high precision. And for the next step, what we've been doing is we are developing and are planning to launch an integrated data dashboard with the spike detection algorithm. So our team members are hard at work on that at this point, share some of the preliminary findings in peer-reviewed publications and reports. One of our very important goals is to develop a protocol for assessment of opioid-related spike detection system and communication. So this would serve as kind of foundation for other communities who may want to revise some of the spike alert system that they have there and focus on different aspects, not just the detection, but also communication part of it. Then our next goal is to implement the spike detection protocol and communication system and complete a phase 2 survey and qualitative interviews to see what has changed among stakeholders, their knowledge of ORIs, and how effective the communication and the new measure has been in reducing the risk of opioid-related events and detecting ORI spikes in the community. So yeah, we have been doing a lot of work in this field, and our goal has been to identify all of the necessary factors and components when it comes to identifying increased opioid-related overdoses in a community and communicating them. And so the next few months are going to be very key. And having all of you here to hear about the work that we've been doing and listen to your thoughts on what we may be missing or what are the positive aspect and negative aspect of the study and the things to focus on would be really, really helpful. And again, thank you so much. And here are our contacts if you want to reach out to us about the study and discuss our findings. And again, thank you so much, dear Orion, and everyone for being here and hearing about the study.
Thank you, Doctor. And it's very interesting, particularly to us who've been on the Lowell task force from the beginning, to hear you use that work, and particularly John Kelly's work. People have questions either for the doctor or for Lauren. Please feel free to unmute yourself. Okay, anybody? I'm trying to just catch up in the chat here. Yeah. Mike, I see you've got a comment in the chat.
That's actually a direct comment to you. It's something else.
Oh, okay. All right, I'll leave that. Okay.
Yeah, just leave
Anybody have any questions, comments? Doctor, if I could ask you a question, what are the key takeaway that you have regarding the non-fatal overdoses? I mean, we look very often here at the fatal overdoses, and Lowell does a great job of tracking those. But what are your sort of key takeaways about intervention in that area?
Yeah, definitely. So when we look at overdoses, and again, going back to the meteorology analogy, when we look at fatal opioid overdose, it's like examining kind of like, the destruction that has already happened after a hurricane. So when we look at the non-fatal opioid overdose, looking at data in real time and try to come up with a predictive model, it's like thinking about providing people an opportunity of potential increase in risk, and not just people who are actively using, but also people in the community who may be, worried about their loved ones, their peers, and that the time, that people can get just to check on people or just to be aware of an increased risk, and the ability to take some precaution because of that, early warning could be very helpful. So, that has been our kind of key motivating factor, is to make sure that people have all the necessary information that they can get to stay safe and to reduce any risk of overdose, which could translate to, again, a fatal overdose, given that, let's say, there's nobody around or nobody there to give naloxone. So that's been the key. And we hope that, the alert system, when improved, can just reduce the time that people, it takes for the information to spread around the community, and therefore, be helpful to people who may be at high risk.
Doctor, are there gaps in that detection system that we could be helpful in filling, like gaps in the data that you're able to get?
Mm-hmm. So there's a couple of gaps. The first one is we primarily work with the non-fatal data. So having rapidly accessible fatal opioid overdose data would also be helpful. The other gap is also regarding drug testing. We don't really have a way to get rapid information on what the content of those drugs were. We have some reporting mechanism that allows for examination of, drug paraphernalia and understand what is going on in the community in a broader scale, in a longer time span, but there's no mechanism to specifically identify what is going on or what drugs were involved in a specific non-fatal opioid overdose that is continuously measured. And it is, again, a challenge to get that information out, because I don't think there is kind of a surveillance mechanism that collects samples of suspected ORI cases and quantifies data. Particularly, it's much more concerning nowadays because there's fentanyl and there's other adulterants. There are other drugs which are non-opioid supposedly contaminated with fentanyl and other adulterants, which creates a high risk, particularly for people who think they're not taking opioids and taking other drugs, and inadvertently receive a very high dose of fentanyl or other contaminants, and they are unaware of that, and potentially this could be fatal. So that is another, risk factor. And, I think there's a lot of group in Massachusetts, and I think Tracy's team is doing great work with that. But again, there is always ample room for improvement in surveillance of drugs and drug contaminants along with EMS measures, which could help us rapidly share information.
All right, and one last question, Doctor, from one of our interns that she writes that she read your paper about GIS and syndemics, and wondering what your thoughts are about looking at xylazine and fentanyl from a syndemics framework.
That's an excellent question. We did not cover that in today's presentation, and it's a whole different story itself. So I just want to give a little bit of a preface about what a syndemic is. A syndemic is kind of a combination of multiple co-occurring epidemics. So opioid overdose, HCV, HIV, and also you can add on top of it poverty and homelessness, all of them acting together to create this mixture of high-risk environment that puts people at very high risk of opioid overdose and other infectious diseases. And I think the question about xylazine and fentanyl from a syndemic perspective is really excellent. We do examine all of these within an overall framework of high-risk environment in competing, risk of infections and overdose. Xylazine and fentanyl, I don't think we have done as much of work regarding connecting them as a syndemic per se, but it does make a lot of sense because the surgence of xylazine in the market, has been because of a specific reason that it makes things gives long legs, and there's reason why people are mixing those drugs together to improve potency and stuff. So again, it is within a syndemics framework, but I think the discussion surrounding that will be much more longer than I think the time we may have today. But then, Anjali, that's a great question, and thank you for bringing that out. And I think Dr. Holcraft's presentation early on, I think, really refers to that, the epidemic of xylazine and fentanyl in the current, setting.
Thank you, Doctor. So I don't want to lose people, but I would just, one thing to tell you that we are working on, and that is purchase of xylazine test strips. It's my hope that we will be able to buy some and then make them available in the community. We're also looking at something that came out of the xylazine training yesterday, which was being able to get some wound care kits, little kits that people could take, particularly people who are unhoused, and then would be able to use those. So I want to thank everybody for being here. Special thanks to all of our presenters today. And our next meeting is Wednesday, July 12th. So we look forward to seeing you all then. Again, thank you. Be well.
Thank you, everyone.